Which is better, 1 or 2? Now which is better, 3 or 4?
Subjective refraction, the procedure of using responses from the patient to determine the refractive correction for the eye. Trial and error or alternate choice techniques are applied in a step-by-step process, with those patients old enough and cooperative enough to respond, to arrive at the best optical correction. In the 19th century, subjective refraction was often performed with rotating discs of spherical lenses for the correction of myopia, hyperopia, or presbyopia. Astigmatism was more complicated to correct, however, and astigmatic dial targets were devised, first to locate the axis of astigmatism and then to balance the refractive correction in the two principal meridians. The astigmatic dials are still used by some refractionists, but they can be difficult for patients to understand. In 1887, Edward Jackson described a fixed-power Stokes lens that he'd recently added to his case of trial lenses. This astigmatic lens, used to refine the power of a cylindrical correction, was the forerunner of the Jackson cross-cylinder as we know it today. Jackson stated that this single lens had come to be far more useful and far more used than any other one lens in his trial set. Indeed, the Jackson cross-cylinder has become the world's standard for accuracy in determining both the cylinder axis and cylinder power in subjective refraction. This program presents the basic theory and clinical steps of subjective refraction using cross-cylinder techniques, as demonstrated by Dr. David Guyton at the Wilmer Ophthalmological Institute of the Johns Hopkins University.
Subjective refraction begins with taking the visual acuity and ends with writing the prescription for glasses or contact lenses. We'll demonstrate the determination of sphere, cylinder, and axis, binocular balancing, and measurement for reading aids. Over-refraction techniques and cycloplegia will also be discussed. Before proceeding with the steps of subjective refraction, though, let's take a quick look at the basics of astigmatism and cross-cylinder testing.
Light from a point on a distant letter chart is shown entering an emmetropic eye and coming to focus on the retina. If the eye is astigmatic, the light will come to focus in two focal lines rather than in a single focal point. The focal lines are oriented in the principal meridians of the astigmatism, here shown horizontal and vertical. The focal lines can be moved forward or backward by adding spherical lenses to the eye, plus lenses to pull the focal lines forward, or minus lenses to move the focal lines backward. Dioptrically midway between the two focal lines is the cross-section of the bundle of rays called the circle of least confusion. The spherical lens which places the circle of least confusion on the retina is called the spherical equivalent of the refractive correction. If the circle of least confusion falls on the retina, each point of the letter chart is equally blurred in all directions. But if the vertical focal line is placed on the retina, the vertical strokes of the letters become clear and the horizontal strokes become blurred. On the other hand, if the horizontal focal line is placed on the retina, the horizontal strokes of the letters become clear. It is important to adjust the sphere to place the circle of least confusion on the retina before testing with the cross-cylinder. This is done by trial and error adjustment of the sphere for best visual acuity. With the focal lines now straddling the retina, the cross-cylinder is introduced with its axes aligned with the principal meridians of the eye's astigmatism. In this flip position 1, the plus cylinder, axis 180, pulls the horizontal focal line farther forward, and the minus cylinder, axis 90, lets the vertical focal line slide farther backward, increasing the amount of astigmatism and thus increasing the blur. The cross cylinder is then flipped to position 2, interchanging the plus and minus axes. Now the plus cylinder, axis 90, pulls the vertical focal line forward, and the minus cylinder, axis 180, lets the horizontal focal line slide backward, decreasing the astigmatism and decreasing the blur. Here's the patient's view of the letter chart as the examiner flips the cross cylinder and asks, which is better, 1 or 2? The patient chooses position 2. The cross cylinder is left in the preferred position, and the cylinder power is added in the orientation indicated by the axes of the cross cylinder. If plus cylinder is added, it is placed with axis 90. If minus cylinder is added, it is placed with axis 180. In either case, when cylinder power is added, only one focal line is moved. For example, if plus cylinder axis 90 is added, only the vertical focal line is pulled forward, and the circle of least confusion is pulled forward half as much off the retina. Before the cross-cylinder test is applied again, the circle of least confusion must be moved back to the retina. This is accomplished by changing the sphere half as much as the cylinder power and in the opposite direction. For example, here the sphere will be changed half as much as the cylinder in the minus direction to move both the focal lines backward and the circle of least confusion back to the retina. The desired result of cross-cylinder testing is neutralization of the astigmatism, with the focal lines collapsing into a point focus on the retina. Now, if the cross-cylinder is introduced, astigmatism is created in flip position 1, but an equal and opposite amount of astigmatism is created in flip position 2. The patient sees flip positions 1 and 2 as equal, the desired balance between the two positions. Note that both positions are slightly blurred. When the cross cylinder is then removed, each point on the letter chart becomes a clear point focus on the retina. The strength of cross-cylinder testing lies in the two-choice balance between the two flip positions, an easy task for the patient. Now the circle of least confusion, or the point of best focus, must be maintained on the retina by proper sphere adjustment during cross-cylinder testing. Otherwise, problems can occur. For example, here's an eye that is slightly myopic, having a point focus anterior to the retina, with no astigmatism at all. Look what happens when the cross cylinder is added to check for astigmatism. In one position, the horizontal focal line falls on the retina, and in the flip position, the vertical focal line falls on the retina. The patient is asked, which is better, 1 or 2? 1 or 2? The patient will choose position 2, because more of the letters are recognizable when the vertical strokes are clear than when the horizontal strokes are clear. The patient will thus be given an astigmatic correction, whatever it takes, to place the vertical focal line on the retina. This is a known artifact of cross-cylinder testing with letter charts, and is avoided by frequent adjustment of sphere to keep the circle of least confusion, or the point of best focus, on the retina prior to and during cross-cylinder testing.
Those were the basics of astigmatism and cross-cylinder testing. We'll return to focal lines and to the circle of least confusion as we proceed through the steps of subjective refraction.
It is usually faster to refine an existing refraction than to start from zero power, so whenever possible, start with the previous correction or with the retinoscopic finding. Most refractionists occlude the eye not being refracted, but some leave it open, blurred by plus lenses. Here, Dr. Guyton begins by occluding the left eye and taking an initial visual acuity for the right eye.
Now read the smallest line you can see on the chart.
A, P, S, O, T, F.
Good. Now watch closely. I'm going to change it. Does this make it better or worse? Ready?
Sphere will be adjusted first for best visual acuity. Note that the instructions to the patient should follow a definite pattern and must be timed to the lens changes made. First, get the patient's attention. Say what will be done. Then ask the patient the appropriate question, stating alternative brief responses, such as, does this make it better or worse? Alert the patient to the change by saying, ready? Then say, there, as the change is made. Let's watch.
Good. Now watch closely. I'm going to change it. Does this make it better or worse? Ready? There.
Notice that sphere is always changed first in the plus direction by dialing down on the sphere dial. This pulls the focal lines or focal point forward, tending to relax accommodation. How much of a change is made? This depends on the present level of vision. The change must be large enough for the patient to appreciate. With vision better than 20/40, quarter diopter changes are used, corresponding to 1 click of the sphere dial. With vision 20/40 to 20/80, half diopter changes are appropriate, 2 clicks on the dial. With vision worse than 20/80, 1 diopter changes may be necessary. The patient will respond to the first change in the plus direction by saying better, worse, or the same. If the response is better or the same, keep going in the plus direction.
Does this make it better or worse? Ready? There.
Better.
Good. Now, is this still better or worse? Ready? There.
That's worse.
Good.
Notice that as soon as the patient said worse to continued change in the plus direction, the last change was canceled, completing the initial adjustment of sphere. If the response to the first change in the plus direction is worse, the change is not only canceled, but testing is then performed in the minus direction. Let's listen to the proper instructions.
Now, watch closely. I'm going to change it. Does this make it better or worse? Ready? There.
That's worse.
Okay, now I'm going in the other direction. Does this make it better or just smaller and darker? Ready? There.
Better.
Good. Can you read farther down on the chart?
T-Z-V-E-O-L.
Fine. Now, is this still better or just smaller and darker? Ready? There.
Just smaller and darker.
Good.
The first change in the plus direction made vision worse, so the plus change was removed. The first change in the minus direction made the vision better, as documented by the patient's reading smaller letters. The next change in the minus direction made the letters just smaller and darker, as happens when the patient begins to accommodate. This last change in the minus direction was therefore removed, and adjustment of the sphere was complete. Let's watch this last sequence from the patient's view.
Now, watch closely. I'm going to change it. Does this make it better or worse? Ready? There.
That's worse.
Okay, now I'm going in the other direction. Does this make it better or just smaller and darker? Ready? There.
Better.
Good. Can you read farther down on the chart?
T-Z-V-E-O-L.
Fine. Now, is this still better or just smaller and darker? Ready? There.
Just smaller and darker.
Good.
When the sphere is changed in the minus direction, the letters may first become smaller, darker, and clearer. If too much change in the minus direction is made, however, the letters do not become any clearer, but will still appear to become smaller and darker if the patient accommodates. It is important, therefore, to use the exact words better or just smaller and darker when changing sphere in the minus direction. Even so, some patients ask for too much minus sphere because they do not detect the letters only becoming smaller and darker when they begin to accommodate. Continued better responses in the minus direction should be confirmed by asking the patient to read smaller letters. Each quarter diopter change in the minus direction should improve vision almost a whole line near the lower end of the chart.
The technique of adjusting the sphere for best visual acuity will be used over and over again during the remainder of the subjective refraction. Remember to always test in the plus direction first to avoid stimulating the patient's accommodation. Cross-cylinder testing comes next.
The cross cylinder on this Reichert phoropter is a quarter diopter cross cylinder, the one most commonly used when visual acuity is 20/30 or better. If visual acuity is between 20/40 and 20/80, however, a handheld half diopter cross cylinder should be used. With vision worse than 20/80, a handheld 1 diopter cross cylinder may be necessary. Again, the change must be great enough for the patient to detect. As vision improves during the refraction, the lower power cross cylinder should be used for greater sensitivity. The cross cylinder will decrease the patient's vision, typically by 1 or 2 lines when it is introduced. It is thus important to be sure the patient has adequate sized letters to see during cross cylinder testing, usually 1 or 2 lines larger than the best vision obtained from adjustment of sphere. If a previous correction is in place, cylinder axis is refined first, followed by cylinder power. If no cylinder is present, however, it is most efficient to look for cylinder first with the cross-cylinder axes oriented in the 90 and 180 degree meridians. More patients have astigmatism with a vertical or horizontal axis than an oblique axis. The patient is asked to choose between the 2 flip choices. Again, it is important to get the patient's attention, say what you're going to do, ask a question with limited answers, and call attention to the change. Let's listen from the start.
Okay, now watch closely. I'm going to give you a choice. Which is better? 1, or 2? 1 or 2?
They're about the same.
Good.
Before concluding that there is no astigmatism, the test must be performed in a second orientation, preferably with the cross-cylinder axes in the 45 and 135 degree meridians.
Now which is better, 3 or 4? 3 or 4?
3's better.
3. Good.
The cross cylinder in the preferred position indicates that plus cylinder should be added with axis 135 or minus cylinder with axis 45. This is a plus cylinder phoropter, so the axis is rotated to 135 and 2 clicks of plus cylinder are added, changing the sphere 1 click in the minus direction to keep the circle of least confusion on the retina. The flip choices are presented again, and cylinder power is added until the 2 choices are roughly equal.
Now which is better, 7 or 8? Or about the same? 7 or 8?
About the same.
Good.
Once the rough cylinder power is in the phoropter, the cylinder axis can be refined. Cylinder axis is always refined before cylinder power because the correct axis can be found in the presence of an incorrect cylinder power, but the correct cylinder power cannot be found if the axis is wrong. Cylinder axis is refined by rotating the cross cylinder until its axes straddle the correcting cylinder axis. On this Reichert phoropter, the cross cylinder loop is synchronized with the cylinder axis, and the cross cylinder clicks into place exactly in the straddling position.
Now which is better, 1 or 2? 1 or 2?
2.
Good.
The cross cylinder is left in the preferred position, and the cylinder axis is moved 5 or 10 degrees toward the corresponding axis of the cross cylinder. Notice that the cross cylinder rotated 2, remaining synchronized with the cylinder axis. Here, the plus cylinder axis of the phoropter was moved toward the white plus cylinder axis of the cross cylinder. If the phoropter were a minus cylinder model, the cylinder axis would have been moved toward the red minus cylinder axis of the cross cylinder.
Which is better now, 3 or 4? 3 or 4?
3.
3. Now, 5 or 6, or about the same? 5 or 6?
They're about the same.
Good.
It is helpful, as balance between the 2 choices is approached, to offer the third alternative, about the same. Let's see the same sequence from the patient's view.
Which is better now, 3 or 4? 3 or 4?
3.
3. Now, 5 or 6, or about the same? 5 or 6?
They're about the same.
Good.
Even when the choices appear equally clear, there are often small differences in distortion between the 2. For example, the letters in this choice 5 are slightly elongated vertically, and those in choice 6 widened horizontally. This is unavoidable with ordinary cross-cylinder testing, and the patient must simply be asked to compare the clarity of the letters between the 2 choices.
To avoid confusion in cross-cylinder testing, it's best to use numbers such as 3 or 4, 5 or 6, instead of always asking which is better, 1 or 2. It's also best to give 2 fresh choices each time, such as which is better, flip 1 or flip 2, rather than asking which is better, 1 or flip 2. Each flip is helpful in catching the patient's attention and in speeding up the process. Sometimes the patient seems to be leading you in a circle when refining the axis. This happens when the patient keeps choosing the second choice, usually because you have presented the first choice too quickly. If you suspect this is happening, reverse the order of presentation to check for consistency. I do this by asking, which is better, flip 1 or flip 2? If the patient now chooses the second choice, he has contradicted himself and more care must be taken in the testing. Cross-cylinder testing is not foolproof. Let's now refine the cylinder power.
Cylinder power is refined by rotating the cross cylinder until its axes are parallel and perpendicular to the correcting cylinder axis. It clicks into position on this Reichert phoropter.
Now which is better, 1 or 2? 1 or 2?
1.
1. Good.
Again, the cross cylinder is left in the preferred position and cylinder power is added or subtracted in accordance with the position of the cross cylinder axes. Here, the plus cylinder axis of the cross cylinder is aligned with the plus cylinder axis of the phoropter, indicating the need for more plus cylinder power. 2 clicks of cylinder power are added, and the sphere is moved 1 click in the minus direction.
Which is better now, 3 or 4? 3 or 4?
3's better.
3. Now which is better, 5 or 6? Or are they about the same? 5 or 6?
They're about the same.
Good.
Let's see the same sequence from the patient's view.
Which is better now, 3 or 4? 3 or 4?
3's better.
3. Now which is better, 5 or 6? Or are they about the same? 5 or 6?
They're about the same.
Good.
With refinement of cylinder power completed, the cross cylinder is removed and sphere is refined for best visual acuity, testing in the plus direction first as before, and then in the minus direction if necessary. If any significant changes are made in cylinder axis, cylinder power, or sphere during the refinement steps, the sequence should be repeated until no further changes are made. Again, the order of final refinement is always cylinder axis, cylinder power, and sphere. Let's follow the refraction of the left eye without interruption.
Okay, let's go over to the left eye. Look at the chart now. How far down on the chart can you read?
OFLCT.
Any further?
APECTF.
Okay, good. Now watch closely. I'm going to change it. Does this make it better or worse? Ready? There.
Worse.
Okay, let's go the other direction. Better or just smaller and darker? Ready? There.
That's better.
Okay. Again, still better or just smaller and darker? Ready? There.
Better.
How far can you read now?
TZVECL.
Okay, one more time. Better or just smaller and darker? Ready? There.
Just smaller and darker.
Good. Now, I'm going to give you a choice. Tell me which is better, number 1 or 2?
2.
2. Good. Okay, 3 or 4, or about the same?
4.
4. Okay, 5 or 6, or about the same?
About the same.
Good. Now, 3 or 4?
3.
3's better. Okay. 5 or 6?
5.
5. Good. 1 or 2?
1.
1. Good. 3 or 4?
About the same.
Good. Once again, which is better, 1 or 2, or about the same?
About the same.
Okay. How far down on the chart can you read now?
OHPNTZ.
Good. Now watch again. I'm going to change it. Is this better or worse? Ready? There.
That's worse.
Okay, let's go the other direction. Better or just smaller and darker? Ready? There.
Just smaller and darker.
Good. Read the line one last time.
OHPNTZ.
Very good.
Some refractionists use the red-green or duochrome test to refine the final sphere. The patient should be a little fogged by adding a little plus sphere power to about the 20/25 vision level before introducing the test, for the red-green target provides poor control of accommodation. With the patient slightly fogged, the red side should appear in better focus than the green side, for the red rays focus farther back toward the retina than the green rays. The patient is instructed.
Now look at these letters. Are they blacker and sharper on the red side or on the green side?
The red side.
Good.
He changes the sphere a quarter diopter in the minus direction.
And now, are they equal yet?
No, the red side's still better.
Equal yet?
Now they're equal.
Good.
The correct endpoint is when the two sides are equally clear, which places yellow rays, midway between the red and the green, in focus on the retina. Once each eye is refracted, and assuming corrected visual acuity is essentially the same in the two eyes, many refractionists perform binocular balancing. This is to be sure that the level of accommodation is balanced between the two eyes, which may not have been the case during the monocular refractions. One method of binocular balancing uses the 6-prism diopter base-up prism before the right eye to dissociate the two eyes. Some practitioners feel that this is too much prism and prefer to use 2-prism diopters of vertical prism before each eye for a total of 4-prism diopters of vertical separation. A 20/40 line of letters is presented with the patient seeing 2 lines of letters, one above the other. The right eye sees the lower line. Both eyes are fogged, and the patient is asked if both lines of letters are equally blurred. If the patient reports the lower line to be clearer, more plus power is dialed in before the right eye until the lines are equally blurred. The 6-prism diopter prism is then removed. The smaller lines are shown binocularly, and sphere is changed binocularly in the minus direction until best vision is reached.
Once binocular balancing has been completed, the patient should be perfectly focused at the distance of your visual acuity chart. If your chart is at 4 meters, you can dial 1 click up on both sides to move the patient's far points from 4 meters to infinity. I do this for hyperopes who are used to seeing absolutely clearly in the distance, but I usually leave myopes focused at the end of the room. If your visual acuity chart is at 20 feet or 6 meters, dialing a quarter diopter up on the phoropter will place the patient's far point only a 1/12th diopter beyond infinity. Fourier testing using the Maddox rods built into the phoropter is included by some practitioners as part of the refraction. We'll not take the time to cover Fourier testing in this program, though, but rather we'll consider Fourier testing as part of the examination of ocular motility.
If the refractive findings are high, more than 5 or 6 diopters of sphere, the vertex distance of the refraction should be taken into account, the distance from the patient's cornea to the corrective lens. The Reichert phoropter has a sighting device on the side to view the patient's cornea. By using the forehead rest to align the apex of the patient's cornea with the marks in the sighting device, the vertex distance is set at 13.75 millimeters. Most refractionists, though, are in the habit of placing the correction in trial frames. The high-power sphere is placed in the rear cell, and loose trial lenses are used to refine the spherical portion of the refraction. The vertex distance is then measured with a distometer or other form of vertex distance calipers. A more convenient and more accurate way of controlling vertex distance during the refraction is to refract over the patient's old glasses. This can be done with loose lenses in trial lens clips, or can be done behind a phoropter, being careful that the patient does not change the vertex distance by pressing hard against the phoropter. If both the over-refraction finding and the patient's old lenses are astigmatic, the two can be added together most conveniently by measuring the resultant combination on an ordinary lens meter. Alternatively, special purpose calculators or computer programs are available to perform the necessary trigonometric calculations.
When should cycloplegia be used for subjective refraction? In general, the refraction through the natural pupil is preferred if accommodation can be controlled. This is because dilating the pupil often uncovers optical aberrations that can alter the refraction. On the other hand, it's often essential to uncover the full amount of hyperopia in a symptomatic young adult or to prevent accommodative spasm during the refraction of a child. Cycloplegia is usually indicated in young patients, in hyperopes in general, in patients with symptoms of intermittent blurring or eye strain, and in patients who ask for excessive minus sphere during the manifest refraction. Tropicamide is usually adequate for adults, refracting 20 to 30 minutes after giving the drops. Cyclopentolate 1% is usually used for children, refracting 30 to 60 minutes later. Some dark-eyed children require atropine given over a 2 or 3 day course for full relaxation of accommodation. Watch out for atropine toxicity, though, with flushing and fever being the most obvious signs, especially in infants. Remember, before giving cycloplegia, that reading ads cannot be determined after the patient is dilated, and phoreas and tropias are often affected.
An important part of the subjective refraction for presbyopes is the determination of the necessary power for reading ads. Many methods are used to determine reading ads. We will only describe the simplest method here. There is a reading card that flips down on the phoropter, but many practitioners prefer to use trial frames to allow the patient to read in down gaze. Extra plus sphere is added to the patient's distance manifest refraction, with the amount of plus sphere estimated from the patient's age. 1 1/4 diopter reading ads are usually the first ones prescribed between the ages of 40 and 45, progressing to plus 2.5 diopters by age 55 to 60. With the trial correction in place, the patient is given a reading card and asked to move the card toward her or away from her until the print blurs in each direction, thus exploring the useful range of near vision. If the range needs to be moved closer, the power of the reading ads is increased. If the range is too close, the power of the reading ads is reduced. It is important to resist the temptation to prescribe more plus power than the patient needs, for reading ads that are too strong are the most common cause of rejection of new glasses. When the final refraction is complete, the results should be recorded. A non-cycloplegic refraction is called a manifest refraction, usually abbreviated capital M. Sphere, cylinder, and axis are recorded for each eye, along with the visual acuity obtained. The reading ad is also recorded, along with the near visual acuity. If cycloplegia was used, the name of the drug is given, or an abbreviation is used according to local practice. These numbers are not the prescription for glasses or contact lenses. They are simply the refractive findings. Prescribing is the final step, taking into account the type of refractive error, the patient's age and needs, the old glasses, and so forth. Often the refractive findings must be altered for the new glasses to be accepted comfortably.
This concludes our program on subjective refraction. By understanding the basics of astigmatism and cross cylinders, and by practicing the step-by-step techniques we have demonstrated here, you will be well on your way to mastering subjective refraction. Reviewing this program from time to time during the learning process should help, especially in polishing your instructions to the patient for best efficiency. Automated refractors, both subjective and objective, are becoming increasingly reliable and accurate. But there are many situations where there is no substitute for a carefully performed conventional cross-cylinder refraction. For example, if you find yourself in the outback of Australia refracting an Aborigine tribal elder, you will have need of Jackson's special lens. If Edward Jackson were alive today, he would undoubtedly be amazed to see the technological advances in the field of clinical refraction. He would be comforted, however, to visit the outpatient clinics, the private offices, the consulting rooms, and even to look inside many of the automated refractors to find the very same lens that 100 years ago he found was far more useful and far more used than any other one lens in his trial set.
A fundamental component of every eye examination is a determination of intraocular pressure. This assessment provides information on the ordinary function of the eye and assists in the detection of glaucoma. Once you understand the principles, the mechanics of checking intraocular pressure are straightforward. In this videotape, we will review how to measure intraocular pressure by Goldmann applanation tonometry. An individual's intraocular pressure may vary with time of day, posture, exertion, lid movement, medications, and diet. A single reading is only an estimate of the fluctuations that occur. From general population studies, it has been determined that approximately 95% of the population has an intraocular pressure of between 6 and 21 millimeters of mercury. There are a number of factors which have an effect on average intraocular pressure. These include race, refractive error, and age. Elevated intraocular pressure is not limited to the elderly. Glaucoma can occur at any age. Therefore, every patient who is able or willing to cooperate should have intraocular pressure checked regularly. The average intraocular pressure is about 15 millimeters of mercury. Hypotony refers to an intraocular pressure below 6 millimeters of mercury. Hypotony for prolonged periods of time is associated with deleterious effects on the eye. Intraocular pressures above 21 millimeters of mercury increase the suspicion for glaucoma. The higher the intraocular pressure, the greater the likelihood of developing damage to the eye. The optic nerve is most susceptible to this elevation in pressure. A patient with elevated intraocular pressure but no damage to the visual field or optic nerve is considered a glaucoma suspect or ocular hypertensive. If damage in the nerve or visual field is detected, a diagnosis of glaucoma is made. There are a variety of familiar ways to measure the pressure of an object, such as by palpation or by inserting a manometer or gauge. Since this cannot be done in a human eye, indirect methods of tonometry are used. Applanation tonometers measure the force necessary to flatten a corneal surface of constant size. We will concentrate on applanation tonometry with the Goldmann tonometer, since it is generally considered to be the standard to which others are compared. It is attached to the slit lamp biomicroscope and consists of an applanating replaceable tip containing a plastic biprism attached by a rod to the housing piece inside, which contains a coil spring and series of levers that are used to adjust the force of the biprism against the cornea. Two beam-splitting prisms within the applanating unit optically convert the circular area of corneal contact into two semicircles. An important component of applanation tonometry is the tear film meniscus. The tear film meniscus is stained with fluorescein to allow visualization at the margin of contact between the cornea and biprism. As already noted, the circular area of contact is converted by the prisms into two semicircles called mires, seen here through the slit lamp. The force of touch, or applanation, is adjusted until the inner edges overlap. Intraocular pressure is then read directly from a scale on the tonometer housing. The marks on the scale are in 2 millimeters of mercury increments, although intraocular pressure can be estimated to the nearest 1 millimeter. The scale number is multiplied by 10, and this corresponds directly to the intraocular pressure in millimeters of mercury. In performing applanation tonometry, the patient should be seated comfortably at the slit lamp. The chin and forehead should be in their proper rests. A tight-fitting collar should be loosened. There may be difficulty positioning some patients. It helps in these settings to have the patient lean forward in the chair. The patient's eyes should be aligned with this marker on the slit lamp coil. After the slit lamp is turned on to its highest level of illumination, the cobalt blue filter is put into place, and the slit opened to its widest position to achieve the brightest light. The angle between the illumination device and the biomicroscope should be about 60 degrees to best illuminate the tip of the prism.
Low magnification oculars are preferable. With many patients, it helps to preset the tonometer at 20 millimeters of mercury so that less adjustment will be necessary for the specific measurement. Prior to testing intraocular pressure, a topical anesthetic and fluorescein solution, such as Fluoresce, is applied to each eye, and the excess is wiped away. One may also apply fluorescein after administering a topical anesthetic by touching a moistened fluorescein-impregnated strip to the inferior conjunctival cul-de-sac. In order to avoid confusion, check the right eye first, then the left eye. The eye should fixate on a target away from the tonometer. It is important that patients not hold their breath. Rather, they should try to be as relaxed as possible. The lid should not touch the tonometer. If necessary, the examiner can manually keep the lids open, making sure to apply pressure to the bony orbit and not the globe. The slit lamp is moved to approach the cornea along the optical axis. The initial position should be slightly inferior to the visual axis to slip under the eyelashes of the upper lid without touching them. The tonometer is then raised until the prism is centered on the cornea and gently brought forward with the joystick of the slit lamp. The slit lamp should be adjusted up or down to get 2 exact semicircles. Once the tip is properly aligned and positioned, the applanating force on the cornea is varied by turning the dial until the inner borders of the fluorescent mires barely touch. Intraocular pressure is then read from the scale on the tonometer housing. If the instrument is too far away from the cornea, the 2 semicircles cannot be made to overlap. If the instrument is too far forward, the semicircles cannot be separated. At the end point, the semicircles should be bright, symmetric, and sharply focused. If there is too much fluorescein, often from induced tearing, there will be a wide meniscus and an artificially high intraocular pressure reading. If there is too little fluorescein, which may result from evaporation of the stained tear layer during protracted measurement or in a dry eye, the meniscus will be thin and intraocular pressure will be falsely low. The patient should be told to blink several times and the measurement repeated. If pulsatile movement of the mires is noted, the final adjustment should be halfway between the 2 extremes. After each patient, the tonometer tip should be cleaned. Alcohol wipes have been shown to be effective, especially in inactivating most viruses. Make sure the tip is dry before testing the next patient in order to prevent corneal toxicity and maintain reliable readings. Other options for cleaning include soaking in bleach or 3% hydrogen peroxide for 5 to 10 minutes. Although Goldmann applanation tonometry is widely accepted and shown to be highly reliable, it is not without problems. Some of the difficulties are encountered in patients with surface changes on the cornea, including astigmatism, scars, corneal edema, and corneal thinning, or keratoconus. Astigmatism due to abnormalities in corneal curvature of greater than 3 diopters may influence the reading by producing an elliptical area of corneal contact.
This can be minimized by adjusting the axis of the biprism. Convert the patient's refraction from plus to minus cylinder. Then set the red line on the prism holder to minus cylinder on the prism scale. Unlike some tonometers, Goldmann applanation tonometry cannot be performed over a soft or hard contact lens. Patients with marked corneal swelling from trauma or surgery may also be difficult to check. There are some ocular conditions where intraocular pressure may need to be checked with the globe rotated out of primary gaze. For example, in patients with thyroid eye disease, intraocular pressure may be higher in upgaze. After determining intraocular pressure in primary gaze, the patient's chin should be placed behind the chin rest while the forehead is positioned against the forehead rest. Intraocular pressure is then checked with the patient looking up. If nystagmus is present, it is important to have the patient fixate in the field of gaze that maximally diminishes the ocular movement.
Finally, some of the difficulties encountered in the routine, uncomplicated patient may be due to improper calibration. Thus, it is important to periodically calibrate the tonometer every other month. This is done with a short rod of measured weight which is inserted into the housing of the tonometer. The rod has markings for calibration at 0, 2, and 6 grams, corresponding to 0, 20, and 60 millimeters of mercury. At each stop, the tonometer head should move only plus or minus 0.1 grams of the settings. The necessary equipment and instructions for this are included with the applanation tonometer. If proper calibration cannot be achieved, the tonometer should be sent to a service center or the manufacturer. In summary, Goldman applanation tonometry is an important part of a complete eye examination. Developing a routine of testing is essential. Proper positioning of the patient at the slit lamp, maximum brightness of the spot, and good technique will ensure accuracy and reliability for all patients.
Ocular motility disorders commonly occur in infants, children, and adults. As many as 5% of school-aged children have a manifest strabismus, and many adults develop strabismus due to a variety of conditions. This videotape is an introduction to the basic ocular motility examination, which documents and quantitates strabismus, that is, ocular misalignment associated with either abnormalities in binocular vision or faulty neuromuscular control of ocular motility. Specific diagnoses and treatment of strabismus are not covered. However, testing for myasthenia gravis is included since it can mimic any concomitant strabismus. Your guide is Dr. M. Edward Wilson, Associate Professor of Ophthalmology and Pediatrics.
as well as those better able to fixate consistently. However, we should begin with a review of the basic extraocular muscle anatomy, because it leads to a better understanding of the examination components.
Of the 7 extraocular muscles, the 6 rectus and oblique muscles control directional movements of the eye within the orbit. They are the medial, lateral, inferior, and superior rectus muscles, and the inferior and superior obliques. The 7th muscle, the levator palpebrae superioris, elevates the upper eyelid. All muscles are innervated by cranial nerve number 3, the oculomotor nerve, with two exceptions. Innervation for the lateral rectus muscle is cranial nerve number 6, the abducens, and for the superior oblique, cranial nerve number 4, the trochlear. Both the lateral and medial rectus muscles have only horizontal action. The medial rectus is an adductor, and the lateral rectus is an abductor. As the eye looks straight ahead, that is, in primary position, the actions of the superior rectus muscle are elevation, encycloduction, and adduction. When the eye is in abduction, this muscle is almost exclusively an elevator. However, it has more torsional movement in adduction. Since it is easier to observe vertical movements than torsional, it is better to test the function of the superior rectus in abduction rather than adduction. Actions of the inferior rectus muscle are depression, excycloduction, and adduction. When the eye is in abduction, it is almost exclusively a depressor. It is best to test the muscle function when the eye is in abduction because that gives the greatest vertical movement or depression. The superior oblique muscle's primary action is encycloduction, with depression and abduction as secondary actions. Placing the eye in adduction enhances the depression action of the superior oblique, and consequently yields the best direct observation of the muscle function. The primary action of the inferior oblique is excycloduction. Secondary actions are elevation and abduction. Placing the eye in adduction enhances the elevation action of the inferior oblique. Therefore, test the muscle function of the inferior oblique in adduction.
The first thing I do in an ocular motility exam is make sure the patient is comfortable and relaxed because it yields better information. I determine whether or not the patient is able to fixate, since most of the tests are dependent upon fixation. In the case of young children, I sit down immediately so as not to stand over the child. I raise the exam chair to make sure the child is at least at eye level with everyone in the room. Then I address the child directly, complimenting them on their clothing or asking them about school or vacation. Then I begin the exam immediately before taking any additional medical history so as not to lose their attention. Brightly colored toys, pictures, and barking dogs or movies also help to hold their attention.
Begin the exam by having the patient fixate on a distant target and read letters or describe objects. Evaluate head position during fixation by looking for anomalies such as chin up or down, a face turn, or head tilt. Note whether the fixation in each eye is central or eccentric, and if fixation is maintained with each eye. Note nystagmus if it is present. Is the fixation steady or unsteady? The next steps of the exam are based on information gathered by having the patient look in the 6 cardinal gaze positions. They are known as the cardinal positions because one muscle of each eye is the prime mover. The prime movers for each position are called yoke muscles, since they act in concert with each other. The cardinal positions and prime movers are as follows: eyes left, right medial rectus, and left lateral rectus. Eyes right, right lateral rectus, and left medial rectus. Eyes up and right, right superior rectus, and left inferior oblique. Eyes up and left, right inferior oblique, and left superior rectus. Eyes down and right, right inferior rectus, and left superior oblique. Eyes down and left, right superior oblique, and left inferior rectus. Versions are binocular eye movements in the same direction. By evaluating versions in the 6 cardinal gaze positions, it's easy to observe asymmetries in the actions of a pair of yoke muscles. That is, to note underaction or overaction of a muscle when compared to its yoked partner. To test versions, have the patient look left, right, up and left, down and right, and finally down and left. It is also helpful to move an object in front of the patient to examine smooth pursuit movements. This patient's versions demonstrate overaction of the inferior oblique, which produces excessive elevation of the adducted eye. It also produces divergence in up gaze, known as a V pattern, which is secondary to the abducting action of the inferior oblique. These eyes exhibit excessive depression in adduction, which indicates an overaction of the superior oblique. When there is oblique overaction, it is frequently possible to see underaction of the antagonist, as shown here by these underacting inferior obliques. The divergence in down gaze, known as an A pattern, is secondary to the abducting action of the superior oblique. In contrast to versions, ductions are tested under monocular conditions only. They are used to evaluate the range of motion of one eye without any confusion due to fixation with the fellow eye. Ductions may either be full in all positions of gaze or limited. If limited, they may be deficient in one or several directions. In addition to version and duction testing, a neuro-ophthalmic motility exam would include an assessment of the quality of different types of eye movements. However, that is beyond the scope of this videotape.
Next, I perform a series of cover tests because they provide an accurate and reproducible measure of ocular alignment. The patient must be able to fixate on a detailed target, such as the 20/30 line on a standard eye chart. When a significant refractive error is present, the patient should wear corrective lenses during this testing. Use a larger target only if the patient has poor visual acuity.
The first type of cover test is the monocular cover-uncover test. It is the main test to differentiate aphoria, a controlled or latent strabismus, from atropia, a manifest strabismus present under binocular conditions. Cover one eye and look carefully for any movement in the non-covered eye. If the uncovered eye must move rapidly to fixate on the target, atropia is present. When atropia is present, the patient has a deviated eye both before and after the test. Either the same or the opposite eye may deviate depending upon which eye is fixating. Aphoria is demonstrated by movement of the covered eye just after the cover is removed. Since aphoria becomes manifest only when binocularity is interrupted, the patient will have straight eyes both before and after the cover-uncover test.
In some patients, prolonged testing, and therefore prolonged interruption of binocular vision, may temporarily cause complete dissociation from aphoria to a manifest tropia. These are intermittent tropias.
Direction of eye movement defines the type of aphoria or tropia present. An esotropic eye moves outward toward primary position to fixate the target. Conversely, an eye which moves inward toward primary position to fixate is exotropic. Hypertropia is present when the eye moves down to fixate, while a hypotropic eye moves up to fixate. The same movements define phorias as well. If the deviation does not vary with direction of gaze or fixating eye, it is a concomitant strabismus, as seen in this patient with esotropia. However, if the deviation does vary with direction of gaze or fixating eye, even subtly, as seen here, it's an incomitant strabismus. This patient has a hypertropia from a fourth cranial nerve paresis. Usually, paralytic, myasthenic, and restrictive strabismus are incomitant.
Although the cover-uncover test demonstrates an ocular deviation, it doesn't quantify it. To measure the total deviation, it is necessary to perform an alternate cover test with prisms.
To begin the alternate cover test, move the cover from eye to eye several times to dissociate the eyes and achieve maximum deviation. This elicits the total tropia plus phoria. Alternate the cover carefully to prevent fusion from occurring, but not so quickly that the patient can't fixate with each eye. Once dissociation is achieved, measure the amount of deviation with handheld prisms. However, do not allow re-establishment of fusion while reaching for the prisms. A prism is a wedge of refracting material with an angular cross-section which displaces light as it crosses the prism. When the prism power is correct, no movement occurs as the cover is switched from one eye to the other. Strabismus deviation is the amount of prism power required to achieve this effect. This endpoint is called neutralization. The deviation is measured in prism diopters. Each 2 prism diopters are equal to approximately 1 degree for angles under 45 degrees. When recording strabismus measurements, it is common to note them on a tic-tac-toe form on the page. Record them as though the page represents the patient's face as seen by the examiner, with right gaze measurements recorded on the left and left gaze measurements on the right. Always hold the prism with the apex pointing in the same direction as the eye is deviating. American-made prisms are calibrated so that it's most accurate to hold them with the rear surface in the frontal plane. It may be necessary to hold prisms both horizontally and vertically to completely neutralize the shift. This test can be performed in all gaze positions. When measuring large deviations, do not stack prisms together. It is more accurate to place a prism in front of each eye. When measuring in primary position, monitor the patient's head to avoid face turn or head tilt. Measure the patient in right and left gaze by having the patient turn to the side until the nose nearly blocks view of the target. For up and down gaze, have the patient tilt the chin as far down or up as possible. If a cyclovertical deviation is suspected, measure the patient in the 4 oblique positions of gaze as well. The patient has to reach a compromise position in the down and right and down and left gaze positions in order to avoid occlusion of the adducting eye by the nose. Since that position will not always be the same, it is not possible to accurately reproduce these 2 measurements quantitatively. Nevertheless, they are useful measurements in documenting an imbalance. Now measure with the head at a 30-degree tilt to each side while the eyes remain in the straight-ahead position. Finally, perform measurements at near in the straight-ahead position.
I often have the patient hold a stick or card for this measurement because I need both of my hands to test. However, sometimes I have to use a little ingenuity when this is not successful, especially for the very young or inattentive patient. The third cover test, the simultaneous prism and cover test, is especially beneficial with small angle tropias when there may be a coexisting larger phoria. As with other cover tests, the validity of the findings is directly related to the ability of the patient to maintain constant fixation on an accommodative target.
Place the cover over the fixating eye and at the same time place a prism in front of the deviating eye. Repeat the test using larger prism powers until there is no shift in the deviated eye.
I encounter numerous patients who are either unable to fixate or cooperate sufficiently for accurate assessment of ocular motility with cover tests. In these cases, I use corneal light reflection tests to measure the deviation. Since many of these patients are children, I place a bright, detailed toy over or beside the light. It also helps hold their attention to whistle, talk, blink the light, and to change the toys frequently. So I often have to use the concept of one toy, one look.
When the patient fixates on the light reflection should be in a symmetrical position near the center of the pupil. In most eyes, the light reflection will be displaced slightly, either nasally, known as a positive angle kappa, or temporally, known as a negative angle kappa. However, if decentration occurs in one eye relative to the other, either the visual axis is truly decentered, a rare occurrence, or more commonly, strabismus is present, as seen in this patient with congenital esotropia. Note that the light reflection is decentered temporally in the left eye. One way to quantify strabismus with light reflection testing is by the Hirschberg method. It's based on the premise that 1 millimeter of decentration of the corneal light reflection corresponds to approximately 7 degrees or 15 prism diopters of ocular deviation. Therefore, a light reflection at the pupillary margin, which is about 2 millimeters from the pupillary center, corresponds to 15 degrees or 30 prism diopters. Another way to quantify the deviation is with the Krimsky method, which uses prisms to align the reflections in both eyes. Have the patient fixate on a target at near with the better eye. Then place prisms in front of the deviated eye to center the corneal reflection. Calculate the deviation the same as any prism test. Although classically the Krimsky test is done with the prism over the preferred eye, many observers place the prism over the deviating eye. When evaluating incomitant strabismus, it's important to be familiar with Hering's law of motor correspondence. It states that equal and simultaneous innervation flows to yoke muscles. In normal eyes, the consequent movement of each eye is equal.
However, if one of the muscles is weakened, paralyzed, or acting against a restriction, the amount of neural input required to hold primary gaze fixation with that eye is so great that the yoke muscle, the other eye, will overact. The eye deviates because it's receiving more innervation than it needs.
The fixating eye determines the amount of innervation to both eyes. Therefore, the amount of misalignment varies depending upon which eye is fixating. When the normal eye is fixating, the amount of misalignment is the primary deviation. The secondary deviation is the amount of misalignment when the eye with limited movement is fixating. This is larger than the primary deviation because the unaffected eye receives increased innervation. This patient has a right superior oblique paresis. With the prism over the affected right eye, he fixates with the normal left eye and has a 5-prism diopter right hypertropia. With the prism over the normal left eye, he fixates with the affected right eye. Fixation with the affected eye causes a larger secondary deviation. In this instance, a 16-prism diopter left hypotropia. Placing the prism in front of the affected eye accurately quantifies the primary deviation. It's important to note that myasthenia gravis can simulate any concomitant strabismus pattern, especially a paresis as seen in this patient with vertical strabismus and ptosis.
Laboratory tests such as acetylcholine receptor antibody titers, electromyography, and others are useful in the diagnosis of myasthenia gravis. In addition, there are specific tests which differentiate the ophthalmic findings of myasthenia gravis from restrictive or paretic strabismus. They include forced ductions, force generation, and tensilon testing.
To prepare the patient for forced duction and force generation testing, apply a topical anesthetic and use an eyelid speculum if necessary. Ask the patient to look in the direction of the duction limitation. Next, perform a forced duction or monocular rotation of the eye. Grasp the eye with a pair of toothed forceps near the limbus, 180 degrees across from the gaze direction to be tested. When testing one of the rectus muscles, proptose the globe slightly to put the muscle on stretch. If the eye can be easily moved into the field of duction limitation, a paresis is present. However, if the deviation is due to a restrictive strabismus, the eye will not move into the area of duction. This produces a positive forced duction test. To perform a force generation test, have the patient continue to look in the direction of the duction limitation. Pull in the opposite direction with the toothed forceps in order to feel the strength or weakness of the muscle's force. If myasthenia gravis is still suspected, it is prudent to perform a tensilon test. First, inject a 0.2 cc test dose of tensilon intravenously. If no adverse reaction occurs, inject a 0.8 cc dose of tensilon and observe the patient's lids and eye movements. Have atropine available as an antidote in case an adverse reaction occurs. Note any improvement in eyelid position or strabismus. If prisms are not available, a Maddox rod may be helpful in documenting improvement. Hold the rod in front of one eye and have the patient view the red line and white light. As alignment improves, the patient indicates that the line and light appear closer together. There are a variety of methods other than the Maddox rod test to assess alignment during tensilon testing. Whatever method is used, it is crucial to perform it quickly since tensilon is a very short-acting agent. With tensilon testing in myasthenia gravis, eyelid changes are often much more dramatic than changes in strabismus. While most other forms of strabismus are treated with glasses and/or surgery, myasthenia gravis is often treated with anticholinesterase or immunosuppressive medication.
Finally, if I suspect a dysfunction of the levator palpebrae superioris muscle, I test eyelid function.
When the upper eyelid droops, it is known as blepharoptosis, which is often shortened to ptosis. Measure the height of the palpebral fissure in each eye. Then measure the distance between the corneal light reflection and the upper eyelid margin. To estimate the function of the levator muscle, first fixate the brow and then measure the upper eyelid excursion from down gaze to up gaze. Always assess the patient in sustained up gaze. If the levator muscle fatigues and the ptosis worsens, suspect myasthenia gravis. A complete ocular motility evaluation will often contain more specialized techniques and procedures than those presented in this videotape of the basic exam. For information about those techniques and procedures, please consult the sections on Pediatric Ophthalmology and Strabismus and Neuro-Ophthalmology in the Basic and Clinical Science course produced by the American Academy of Ophthalmology.
An organized, step-by-step approach to the basic ocular motility examination can yield useful and accurate data even with uncooperative and very young patients. This will, in turn, allow more successful and earlier treatment to eliminate diplopia, promote normal binocular vision, and prevent or minimize amblyopia.
Retinoscopy, a simple yet powerful technique for determining the refractive correction for the eye. An objective technique which requires no decision or response from the patient, retinoscopy is used for refracting children and often for the initial refraction of adults. Retinoscopy is taken for granted by most refractionists, but is not easy to teach or to learn. Dr. David Guyton and his colleagues at the Wilmer Ophthalmological Institute of the Johns Hopkins University have developed a new retinoscopic attachment to a special low-light level black and white video camera, which allows the retinoscopic reflex in a patient's pupil to be captured on videotape for the first time. An amber color has been added to these scenes for greater ease of viewing and to approximate the true color of the retinoscopic reflex. Even irregular retinoscopic reflexes can be demonstrated, those reflexes which cause so much confusion for the beginning retinoscopist. In this program, step-by-step details of the clinical technique of retinoscopy will be described. Plus-cylinder refracting equipment will be used throughout. Those viewers having minus-cylinder equipment should obtain the alternate videotape using minus cylinders. Neutralization methods rather than estimation methods will be emphasized, both with model eyes and with actual patients. Finally, problem situations such as small pupils, irregular reflexes, and dim reflexes will be demonstrated, along with instruction in how to deal with them. This program will thus provide the background and clinical instruction necessary for the eventual mastery of retinoscopy.
The streak retinoscope was introduced in the United States by Jack Copeland in the 1920s, replacing the older spot retinoscope. The familiar Bausch and Lomb streak retinoscope has changed little in the intervening years. A lamp with a linear filament is moved up or down inside the handle by a sleeve on the outside. For our purposes, we'll almost always hold the sleeve in the up position, projecting a band of light called the intercept. We'll sweep this band of light across the patient's pupil during retinoscopy. Other streak retinoscopes are also available, many of them with bright halogen lamps and handles with rechargeable batteries. The Copeland Optec 360 streak retinoscope, for example, was designed by Copeland in the 1960s primarily for two-handed use with the estimating techniques which Copeland himself mastered so well, but which few of us use. We usually use this instrument with one hand for the neutralization techniques we'll be discussing. Other popular streak retinoscopes in the United States are the Welch-Allen, the Keeler, the Nikon, and the Reichert scopes, each with special features of its own. The basic principles of these retinoscopes are the same as the Copeland scopes, but the sleeves of all of them except the Nikon work in the reverse direction. If you use one of these reverse action scopes, you must almost always hold the sleeve all the way down during the neutralization techniques we'll be using. If you are ever uncertain of the correct position for the sleeve, just hold it all the way in the direction which gives a broad, defocused intercept, not a narrow focused one. For demonstration in this program, I'll use the basic Copeland streak retinoscope. It's widely used, simple, and the sleeve is easily visible. In some situations, the other retinoscopes may be superior, especially when increased light is helpful in retinoscoping through small pupils or through immature cataracts. On the other hand, the extra brightness can be annoying to some patients, especially to children. Remember when I remind you to hold the sleeve all the way up in the remainder of the program, if you use one of the non-Copeland scopes, hold the sleeve all the way down.
Jack Copeland spent most of his life teaching ophthalmologists his techniques of streak retinoscopy. Much of what he taught was retinoscopic estimating the refraction without the use of lenses. Most retinoscopists have never become skilled at estimating techniques because corrective lenses are so easily available. With them, the technique of neutralization is used. Neutralization of the patient's refractive error with the corrective lenses to result in a characteristic appearance of the retinoscopic reflex. Neutralization is the technique to be emphasized in this program. The easiest way to learn retinoscopy is to use a refractor or phoropter with a so-called schematic eye mounted behind. For example, this schematic eye from the Burnell Corporation is easily positioned and taped on the examining chair, keeping it pointed straight ahead. The spherical refractive error, that is, the amount of nearsightedness or farsightedness, myopia or hyperopia, can be adjusted by moving this back portion in or out according to a scale marked on the device. Astigmatism can be added to the schematic eye with a cylindrical trial lens, and this will be done to create unknown refractive errors for practice purposes later. This Copeland-Reineck schematic eye from Benson Optical Company can be used if it's first rotated 180 degrees, with cylindrical lenses being taped on the back of the phoropter. To proceed with retinoscopy, you should sit a comfortable arm's length away, holding the retinoscope in one hand and sitting as far away as possible while still being able to adjust the controls on the phoropter. The distance between the phoropter and the retinoscope is called the working distance and is usually about 2/3 of a meter or 67 centimeters. During retinoscopy, you will sometimes move forward or backward, but should always finish up at the normal working distance of approximately 2/3 of a meter. When the neutralization procedure is finished, the eye will be focused exactly at the working distance. Then, by changing the spherical portion of the refractive correction by 1.5 diopters in the minus direction, the eye's focus is moved out to infinity, or, practically speaking, to the visual acuity chart on the far wall.
So, establishing a constant working distance is important. Retinoscopy is more sensitive to small refractive errors at longer working distances. If your arms are short, however, and you have to sit closer than 2/3 of a meter, you may find later that you have to compensate for your working distance by changing the sphere 1.75 diopters in the minus direction instead of 1.5 diopters to give best visual acuity.
The retinoscope should be held with one hand, using the thumb and forefinger to hold the sleeve in the up position and to rotate the sleeve when necessary. The rim of the scope should be steadied against the brow, with the examiner looking through the peephole at the eye to be retinoscoped. As with direct ophthalmoscopy, the examiner's right eye is used to retinoscope the patient's right eye, and the examiner's left eye is used to retinoscope the patient's left eye. With the room lights dimmed, the blurred streak of light, the intercept, is swept across the pupil. Dr. Guyton comments.
The intercept is always swept at right angles to its length. If it is oriented vertically, it is swept horizontally. If oriented horizontally, it is swept vertically. And if oriented obliquely, it is swept obliquely at right angles to the orientation of the streak. In this vertical orientation, we are actually testing the power in the horizontal meridian, but we often say that we are neutralizing the vertical meridian. We should be saying that we are neutralizing the streak in the vertical meridian. Only small sweeps are necessary, just enough to detect the direction of movement of the reflex. Notice that this reflex moves in the same direction as the intercept. This is called with movement. In another situation, we may see this reflex, one which moves in the opposite direction to the intercept. This is called against movement. At the point of neutralization, the reflex looks like this. It doesn't move at all. The pupil suddenly fills with light as the intercept crosses it.
What determines whether one sees with movement, against movement, or neutralization is simply where the eye is focused. If the eye is very nearsighted and is focused between the phoropter and the retinoscope, you will see against movement. If it is focused at the peephole of the retinoscope, you will see neutralization, that is, no movement. And if the eye is focused anywhere else, for instance, behind the retinoscope, you will see with movement.
Now, the point at which the eye is focused in its relaxed position, that is, in the absence of accommodation, is called the far point of the eye. The far point of the nearsighted or myopic eye is somewhere between the eye and infinity. The far point of the emmetropic eye is at infinity, and the far point of the farsighted or hyperopic eye is, optically speaking, beyond infinity.
The whole point of the neutralization technique of retinoscopy is to use lenses to bring the eye's far point to the peephole of the retinoscope held at the normal working distance. Adding plus lens power, dialing down on the phoropter, pulls the far point toward the eye. Going in the minus direction, dialing up on the phoropter, moves the far point away from the eye. The far point can be moved beyond the retinoscope to infinity and even beyond infinity by continuing to dial up on the phoropter. The far point beyond infinity is actually a virtual far point behind the eye. How does one know where the far point is? By the movement of the retinoscopic reflex. If you see with movement, the far point is beyond the retinoscope, and plus lens power is added to pull the far point into the position of the retinoscope. If you see against movement, the far point is between the phoropter and the retinoscope, and the lenses are changed in the minus direction by dialing up to move the far point out to the retinoscope. When the far point reaches the retinoscope, the reflex becomes neutralized, filling the whole pupil and no longer moving. Dr. Guyton will look at a reflex and move the far point around by changing the lenses.
Here's with movement. The far point must be beyond the retinoscope. That says add plus, dial down on the phoropter to pull the far point inward toward the retinoscope. As we add plus, Notice that the reflex becomes broad and has less distinct margins. It also speeds up as we approach neutralization. The far point is approaching the peephole of the retinoscope. Neutralization is not a sharp, distinct point. There is a zone of neutrality in most eyes at least half a diopter wide, or at least 2 clicks of sphere power on the phoropter. This is sometimes called the dead zone, where neither with movement nor against movement can be distinguished with certainty. As we continue to add plus, the far point is pulled in front of the retinoscope and against movement appears. Against movement tells us, of course, that we need to change sphere back in the minus direction, to dial up on the phoropter to get back to neutralization.
Remember, with movement tells you to change sphere in the plus direction, to dial down on the phoropter. Against movement tells you to change sphere in the minus direction, to dial up on the phoropter. It's really very straightforward. So far, the examiner has remained at the normal working distance and has moved the far point about by changing the lenses in front of the eye. Once the far point is in the vicinity of the retinoscope, however, the zone of neutralization can be examined very precisely by moving forward and backward, like so. If you move forward inside the far point now falls beyond the retinoscope, and you will pick up with movement. The farther forward you move, the more pronounced the with movement becomes. By your moving back beyond the far point comes to fall between the phoropter and the retinoscope, and you'll pick up against movement. The farther you move back, the more pronounced the against movement becomes. As you move forward again, you'll move through the dead zone and pick up with movement once more. By this to and fro movement, you can exactly locate the front edge of the dead zone, where only minimal with movement remains. This is generally the best endpoint. With movement is easier to detect than against movement, and whether you move to the far point or bring the far point to the retinoscope with lenses, the best endpoint is leaving a little with movement. Now it's time to retinoscope an eye with an unknown spherical error. First, set the schematic eye to an unknown spherical value without looking at the scale. Then position yourself at the normal working distance and dim the lights. Be sure to hold the sleeve on the retinoscope up and look for with or against movement.
Here's with movement. That's easy. We dial down to add plus until just a little with movement remains. That's too far. Back one, and we're done. Here's another unknown spherical error. Now there's against movement to start with. The first thing to do here is to dial up. Go in the minus direction until we convert the against movement into definite with movement. Then we dial down as slowly as before until just minimal with movement remains. To be sure the end point is correct, we can move a few centimeters forward to see the increased with movement, and then a few centimeters backward, getting into the dead zone or even seeing a little against movement. This to and fro movement is the mark of a skilled retinoscopist. To be sure you're leaving the right amount of with movement, ask an experienced retinoscopist to check the appearance of the reflex. You should neutralize a series of unknown spherical errors in this way before proceeding further. That's all there is to neutralizing spherical refractive errors with retinoscopy. Unfortunately, there is such a thing as astigmatism, and practically all eyes have at least a little astigmatism. Astigmatism requires a cylindrical lens for its correction, for the refractive error is different in different meridians. Each astigmatic eye has 2 principal meridians at right angles to each other, having the greatest and least refractive power. Each principal meridian can be thought of as having its own far point. So to neutralize astigmatism, we have to move 2 far points to the peephole of the retinoscope. We'll first use spheres to move one of the far points to the peephole. Then we'll use a cylindrical lens to move the second far point to the peephole. The orientation of the cylinder is critical, though, and we first have to locate the principal meridians to know where to place the cylinder axis. Here's where our streak retinoscope is most useful, in locating the cylinder axis, as opposed to the older type of spot retinoscope. Let's give some astigmatism to the schematic eye.
Place a -1.5 diopter cylinder between the schematic eye and the phoropter, with axis approximately vertical at about 100 degrees, so the proper correction will be a +1.5 diopter cylinder, axis 100 degrees. Dim the lights and look for with or against movement. This time not only holding the sleeve all the way up, but also rotating it with thumb and forefinger to change the streak from one meridian to another as you sweep the intercept across the pupil.
Note that the reflex is different in different meridians, indicating the presence of astigmatism. Here is with movement, for example, and here is against. The first step is to get with movement in all meridians by dialing up on the phoropter in the minus direction. This against movement is what we want to convert to with, so we'll dial up until definite with movement. Now there's with movement in all meridians as we check around. The next step is dialing slowly back in the plus direction until we neutralize the first meridian that neutralizes. The reflex is broader in the horizontal meridian, so we'll concentrate on that reflex. There. Just a little with movement remaining. Now the vertical meridian has the most remaining with movement, indicating the axis of the plus cylinder that we'll need.
Here is the only place that you should ever lower the sleeve in the neutralization technique. If there is more than 1 diopter or so of astigmatism, you can enhance the reflex, making it narrower and brighter, by adjusting the sleeve downward.
Notice that both the intercept and the reflex become narrower and brighter as we seek the position of the sleeve, giving the best enhancement. Enhancing the reflex serves only to help locate the cylinder axis with better precision, and you should never attempt to neutralize the reflex when it is enhanced. If the reflex will not enhance, return the sleeve to the extreme up position. With the reflex enhanced if possible, we will now examine the various phenomena that help us locate the cylinder axis. First, the break phenomenon. Note that when the intercept is off axis, the reflex is no longer parallel to it. There is a break or misalignment of the reflex with the intercept. As we rotate the streak on axis, the reflex becomes parallel to the intercept. Thus, the break phenomenon, when present, tells us there is astigmatism and that we're off axis. Also note that when the intercept is off axis, the reflex becomes thicker and usually less bright. That is, the reflex appears less enhanced. Thus, the best enhancement of the reflex occurs when we are on axis. The last phenomenon, the skew phenomenon, is most helpful with low amounts of astigmatism. We'll temporarily correct most of this astigmatism to demonstrate the skew phenomenon. Now the desired axis is still roughly vertical, but there is no longer enough astigmatism to give a decent break phenomenon. Note instead the apparent direction of movement of the reflex with respect to the direction of movement of the intercept. If the intercept is off axis, the reflex moves in a skewed direction with respect to the intercept. If the intercept is on axis, the reflex and intercept move in exactly the same direction. The skew phenomenon is thus a dynamic clue to the axis location, whereas the break and enhancement phenomena are static clues. Again, the skew phenomenon is most useful in low amounts of astigmatism when the other phenomena are less evident. In actual practice, we don't think of these separate phenomena when locating the axis. They all blend together with experience. Now that we have located the axis, we rotate the cylinder axis of the phoropter parallel to the streak with the greatest with movement. This remaining with movement is neutralized by adding plus cylinder power, turning the cylinder knob clockwise on this Reichert phoropter. There, just a little remaining with movement. Check the horizontal meridian to see if it's still neutralized, and we're finished with the gross neutralization. Each principal meridian is neutralized. Many retinoscopists stop at this point and proceed to subjective refinement of the refraction. It's good practice, though, to refine the cylinder axis and power retinoscopically first, for such refinement is easy and fast with the streak retinoscope. Let's leave a little axis error and power error so we can demonstrate these refinement steps more easily. For both refinement steps, we need definite with movement in all meridians, so we lean a little forward a few centimeters to obtain it. First, we refine axis. Having moved in to get with movement in all meridians, we use what Copeland called the straddle cross. We check the reflex 45 degrees on either side of the correcting cylinder axis. If there is an axis error, the reflex will be narrower and brighter, showing better with movement in one of these directions. Here this occurs 45 degrees counterclockwise to the axis. This narrower, brighter reflex is called the guide line, and the plus cylinder axis should be rotated a few degrees toward it. The straddle cross is checked again, and the axis refined further if necessary until the reflexes 45 degrees to either side of the axis are equal. Refinement of the cylinder axis using the straddle cross is recognized as one of the most accurate steps in retinoscopy, and as you see, is both easy and fast. Next comes final refinement of the cylinder power. Again, we move in a few centimeters from the normal working distance to pick up definite with movement in both principal meridians. Now we use what Copeland called the power cross. We compare the with movement in the two principal meridians back and forth as we slowly move backward to the normal working distance. Here we see that the with movement is unbalanced between the two principal meridians, that we need more plus power to neutralize the streak in the vertical meridian. The vertical meridian is parallel to the cylinder axis, so we need to add more plus cylinder power to decrease the with movement. Like so. We check the power cross again. This time it appears balanced, and it stays balanced as we move slowly outward to the normal working distance. That completes the neutralization of this astigmatic eye. You should repeat the procedure using different amounts of simulated astigmatism and have an experienced retinoscopist check your neutralization of the reflex. Don't trust the refractive scale on the schematic eye, and don't even expect to get a cylindrical correction exactly opposite to the trial cylinder you added behind the phoropter, for the two lenses are separated, and this can make a difference. Also note that except for clearing the cylinder power initially, we have not yet had to pay any attention to the actual sphere and cylinder powers in the phoropter. Instead, we know which way to turn the dials into knobs by the type of reflex we see. The actual lens powers are not important until it comes time to record the results.
You're not yet ready to record the results, though, or even to move on to subjective refinement with a patient, for the eye's far point is still at the working distance. That is, the eye is still focused at the position of the retinoscope. To move the far point to the far wall, or essentially to infinity, you must change the sphere 1.5 diopters in the minus direction. Again, there's no need to look at the numbers. Simply dial 6 clicks up. If your working distance is shorter than normal, you may find that 7 clicks up gives you best visual acuity. Instead of compensating for the working distance by changing the sphere dial, the auxiliary setting R on the Reichert phoropter brings in a retinoscopy working lens of plus 1.5 diopters. This is dialed in at the beginning of the retinoscopy and simply removed at the end. Many retinoscopists prefer not to use this extra lens, for it increases the number of reflections to worry about. Once neutralization of the schematic eye is mastered, it is time to turn to real patients with real eyes. The phoropter is first placed in a comfortable position for the patient, with both eyes open, and the interpupillary distance set to center the patient's eyes in the apertures. The lens dials are set to 0 cylinder and plus 1.5 diopters sphere on both sides. The plus 1.5 diopters of sphere place the emmetrope's far point at the normal working distance. Also, this plus sphere power makes most patients myopic, fogging the distance fixation target and tending to relax accommodation. If the patient turns out to be more than 1.5 diopters hyperopic, more plus sphere may be necessary for proper fogging. Learn to retinoscope the patient's right eye with your right eye, and the patient's left eye with your left eye. This allows the patient to look past your ear with the eye not being retinoscoped at a small fixation light at the end of the room. You need to be as close to the patient's visual axis as possible for the best accuracy. And if the patient does not have strabismus, using the other eye for fixation is the best way to achieve the proper alignment. Retinoscoping off-axis more than 15 degrees introduces significant unwanted astigmatism. Keep both of your eyes open if possible. It's easier to do this if the room is quite dark. The best fixation target is a small light. A projected letter can stimulate accommodation, and large bright fixation targets produce annoying reflections in the corrective lenses.
There is no way to avoid entirely the reflections of the retinoscope light in the phoropter lenses, and one simply has to move slightly to one side or the other to see past the reflections. Should dilating drops be used for retinoscopy? Probably not. The natural pupil is the one the patient ordinarily uses for seeing, and optical aberrations uncovered by dilating the pupil can cause confusing reflexes and even yield a different refraction. For starting out in retinoscopy, though, you will probably appreciate the more obvious reflexes obtained with the pupil dilated. If dilating drops are used, the patient can be instructed to look directly at the retinoscope light, with the other eye occluded. Now we'll neutralize each eye in turn. For the right eye, I see against movement initially, so I dial up to get with movement in all meridians. There, the against movement is gone. It is obvious that the 80-degree or so meridian is neutralizing first, so I concentrate on that meridian and change the sphere slowly in the plus direction to neutralize almost all the with movement. 90 degrees away, I find the maximum remaining with movement, and I locate the axis precisely by lowering the sleeve to enhance the reflex. I align the cylinder axis with the intercept, raise the sleeve, and neutralize the second principal meridian. There, almost neutralized. Good. I check the other principal meridian quickly, and now I move forward slightly to pick up definite with movement and check the straddle cross for axis refinement, 45 degrees on either side of the cylinder axis. This is the brighter reflex, so I'll move the axis slightly clockwise and check again. These look equal. Now, comparing the principal meridians as I move slowly back to the working distance. And they appear to be neutralizing equally as I move back.
The neutralization is finished. After neutralizing the left eye as well, dial 6 clicks up on both sides to compensate for the working distance, moving the patient's far points to the visual acuity chart at the end of the room. Occlude the left eye and take a visual acuity for the right eye. This should be followed by subjective refinement of the refraction whenever possible.
Tell me, what's the smallest line in the chart you can read?
TZVECL.
Good. Very good. Now we'll go to the other eye.
When the refraction is finished, the results are recorded in terms of sphere, cylinder, axis, and visual acuity for each eye. An abbreviation such as RNS is used if the refraction was a retinoscopy alone, CRNS if a cyclogyl retinoscopy, M if the retinoscopy was done without drops and subjectively refined, and so forth, according to the abbreviations used in your area. Retinoscopy is often performed without the phoropter, especially with children. Trial frames can be used if the child is cooperative enough, or the lenses may have to be handheld, especially with infants. Turning all the lights totally off in the room and making barking or other noises to attract attention will also help with infants. Some retinoscopists like to use so-called retinoscopy racks for the refraction of young children, especially for examination under anesthesia in the operating room, where complete trial lens sets may not be available. In this case, each principal meridian is neutralized with spheres only, and the results are usually recorded in the form of an axis cross. If the streak in the vertical meridian neutralizes with plus 4.50 sphere, subtract 1.5 diopters of plus sphere for the working distance and write plus 3.00 for the vertical axis. If the streak in the horizontal meridian neutralizes with a plus 2.50 sphere, write plus 1.00 for the horizontal axis. Note that axis labeling is being used for this usual retinoscopy diagram. Power in the meridians is not being labeled, for the power would be 90 degrees away from the axis locations. The spherocylindrical form of the refraction would then be written plus 1.00 plus 2.00 times 90, with the cylinder being the difference between the two principal meridians. One of the best time-saving applications of retinoscopy is in over-refraction. Holding up plus 1.50 spheres before a child's glasses, with a child looking at a distant target without drops, is the quickest way of confirming that the glasses are correct or are close enough to correct that they don't need changing. Over-retinoscopy can also be performed with greater accuracy of axis settings with trial lens clips on the glasses. This is especially useful when refracting over high-power glasses where the over-refraction technique is so important in controlling the effects of vertex distance and pantoscopic tilt. If retinoscopists had all the expertise and experience of Jack Copeland, they could use estimating techniques, without lenses, to come very close to the best correction. Copeland used neutralization by moving back and forth, enhancement of the reflex by spiraling, and filament focusing by dropping the sleeve and moving close. All methods to estimate in the various ranges of refractive correction. Instruction manuals for his retinoscopes provide further explanation of these estimating methods. Before finishing, Dr. Guyton will take a look at common problems with the retinoscopic reflex and will discuss what to do in each case.
Here we are retinoscoping a patient without drops, and suddenly the pupil constricts and the reflex changes. What happened? The patient looked directly at the retinoscope light. Redirect his attention to the end of the room. That's better. In this second patient, the reflex is changing spontaneously during the retinoscopy. The patient is either accommodating or relaxing his accommodation. This is especially likely to occur in children where distance fixation and fogging are not enough to control accommodation. Cycloplegia may be necessary in these cases. In this next patient, we suddenly notice the reflex spontaneously changing, but not from accommodation. Notice that it changes in brightness as well as in its movement. It often becomes whiter as well, but we cannot show that here. The patient is looking off to the side, and you are either retinoscoping nasal retina or the optic disc. Redirect his attention to the fixation target at the end of the room. That's better. What about irregular reflexes? In this young child with a dilated pupil, the central portion of the reflex has with movement, but the peripheral portion has against movement. This is spherical aberration, common in young eyes. This is easy enough to deal with. We simply neutralize the center of the reflex and ignore the myopic periphery. Spherical aberration is also present with nuclear sclerotic cataracts, but here the center portion of the pupil is myopic. The central reflex shows against movement, and the periphery shows with movement. Here's the real problem reflex, scissors movement. There's nothing magical about scissors movement. It simply means that the different portions of the pupil have different refractive errors, sometimes differing by 4 or 5 diopters or more. It's impossible to neutralize the entire reflex, so we try to pay attention to the central portion. This is still difficult to do, though, and subjective refinement of the refraction is especially valuable in these cases if the patient is old enough. Eyes with marked scissors movement can often obtain good visual acuity, indicating that only a portion of the pupil is used and that the stray light through the other portions of the pupil is effectively ignored. Because we cannot predict which portion of the pupil the patient uses, though, subjective refinement is particularly important with irregular astigmatism such as this. Here's a case of gross irregular astigmatism caused by keratoconus. The irregularity is so great that a dark space often appears in the center of the reflex. Most of these patients will require a contact lens to cover the irregular cornea. A different problem occurs with small pupils. The pupil is so small that the edges of the reflex are hard to see. The best trick here is to move closer, at least temporarily, to see the reflex better. Sometimes, even with a large pupil, the reflex is dim and indistinct. The first thing to think of here is a high refractive error, for the reflex in high refractive errors always appears dim at first. Crank in large amounts of plus or minus sphere to try to improve the reflex, like so, and then continue to neutralize the reflex. If the dim reflex is not improved with high plus or high minus sphere, suspect a cataract or other cause of cloudy media. Try to move in closer to get a brighter reflex, or use one of the new retinoscopes with a bright halogen bulb. Those are most of the problems you'll encounter with the retinoscopic reflex. This concludes our program on retinoscopy. By practicing first with a model eye and then with patients, as we have demonstrated here, you should soon be able to perform retinoscopy with ease. Reviewing this program from time to time during the learning process should help, especially in polishing your retinoscopic refinement techniques and in recognizing and in dealing with problem reflexes. Remember, Jack Copeland is watching over you. Good luck.